All right, welcome back, everybody. Last time we talked about that primary assessment. Let's go back and again, we got to make sure air is going in and out. Okay, whatever we've got to do to assure that. Once we do that, now let's get to the more probably effective way of finding out exactly what's happened to this patient. Hopefully, we can find this stuff out. Again, and that's getting a good secondary assessment on this patient, a good history and physical. Obtain your sample, get your OPQRST, get your past history. What led to this? And usually you're going to get a story from either the patient or the bystanders. Now, don't super question them on that, especially if they can only sound one or two words that you found that out during their primary assessment. Again, you don't want to push that issue, okay? If it is a very prudent question, if you've got a patient with a lung disease that's a little bit older and you ask them, have you ever been intubated before? Have they ever had to put a tube down your throat? And matter of fact, some of them will actually be pointing to their throat when they get there. That usually means that they know that they need to be intubated. So ask the patient if he has any known respiratory diseases. Make sure that the disease might be affecting ventilation, diffusion, or both. Remember, you can have them affect any one of these three: congestive heart failure, COPD, pneumonias, traumas in the past. All of these things can play a factor in that. And then the history of their medication use is very essential. Did you take your inhaler? Again, if they've taken 8 drags off of their inhaler in the last hour, yeah, no wonder they've got a tachycardia at 130, okay? So double check that, make sure that they've taken their prescribed meds when they're supposed to, and if they've been using that rescue inhaler, we definitely want to know it. Did you take extra Lasix? These are things that we really need to know about. Again, look for those drugs that suggest pulmonary disease: albuterol, Atrovent, Ventolin, Xopenex. All of those lovely drugs, okay? If you see the nebulizer unit, that's the dead giveaway. Ask about drugs for cardiac conditions and inquire about their medicine allergies, okay? So yes, an allergic reaction can cause this problem. Remember, pursed lips, guys, means they're trying to auto-peep themselves. They're trying to re-inflate those lungs, those little alveolar sacs, okay? They're trying to recruit them so they can get more gas exchange, so they can offset probably the acidosis that's starting to build up in their system, okay? Increased sputum is more suggestive of a lung or bronchial passage. In a COPD patient, you got somebody that's already got a lung compromise. That additional infection is going to be horrific for them, okay? So, and as a matter of fact, here's the other problem. They're rather prone to getting them, okay? Because, again, part of their lung doesn't work, which means also the macrophages in there don't work like they're supposed to. They're very prone, again, to getting lung diseases, all right? So look for the jugular veins as evident in distension. Again, it means you got a backup. Again, make sure that you inspect, palpate, percuss, auscultate. All of these things are kind of important, but especially, I would say, if anything, the auscultation definitely. I want to know. Check for front and back for abnormalities, for tenderness, any type of crepitus, or if you're actually feeling a little. COPDers can actually start to air trap to the point where the air escapes from the lung and forms up in the subcutaneous tissues. They get that Rice Krispie type feel. By the way, not good, by the way, if they're doing that. Again, you can limit the percussion on these guys, but if I think that I got a pneumothorax, again, I want to hit it, and I want to tap on it. Again, I usually spread the fingers. I usually spread these two, and I kind of thump on it. And the reason that I thump is because if I hear a higher pitched sound, that usually means that, ooh, there's air trapped in there, okay? So again, and then auscultate. That's probably your big one, folks. Listen for the wheezes and listen for the differences in the wheezes. Again, fluid in the lungs have more of a musical quality to them, where the wheeze of a air trapping it stays one tone, okay? Hint for your essay that you might be doing in the very near future, okay? So, again, inspect, auscultate, do all those things, listen. Now, what we call normal breath sounds, or bronchial or bronchovisicular, these are terms that we use to say that they're a normal breath sound, okay? And again, it's a high pitch to hurt over the trachea. Usually the expiratory phase lasts a little bit longer than the inspiratory phase. Now, it shouldn't last too long, okay? And again, those are your broncho. They're the softer one. The expiratory and inspiratory phases are equal. So those are actually, when I think of a normal breath sound as bronchovisicular, if I hear the slow pitch, again, is it's heard in the lungs peripherally. But guys, most of the time you're going to have this one right here, bronchovisicular sounds. Your abnormal sounds, of course, snoring, Snyder, wheezes, rhonchi. Snoring and stridor are both in the upper airway. All these guys are usually down in the lower airways. Tightening, thick junk, thin water, pleural friction rub, no water. Okay? They're tight, thick junk, crackles, thin fluids, pleural rubs, no water. Okay? And it's very important that we understand that and understand the difference between them. Okay? Now, so look at their extremities, check for cyanosis, check for any type of clubbing of the fingers, any cardiopulmonary spasms. If they're curling in their hands like so, probably because their carbon dioxide levels are like 15 to 16. By the way, we have a tool that checks that, by the way. I'm not sure if they're hyperventilating. Put the capno on them and take a look, okay? If they're doing this number, they've got a really low capno and they're breathing 50 times a minute, hyperventilation. Yes, we can tell that in EMS nowadays, okay? All right, let's talk about some of these things. The clubbing of the finger, that's your normal fingernail. But if they're taking a lot of prednisone or there's a change in their oxygenation levels, again, you're going to get a clubbed fingernail where that angle is going to be a whole lot different. Let's see here. 160. Good. All right. But this guy right here is 180. All right. So that clubbed finger is usually is a sign of hypoxia. Okay. Or prolonged exposure to hypoxia. Tachycardia, again, usually when you start having trouble breathing, usually your heart rate goes up. It's kind of a standard thing that happens. Pulsus paradoxus usually have with COPD and cardiac tamponade. What is pulsus paradoxus? Is again when the narrowing of the pulse pressure or the pulse disappears on your the pulse disappears when you take a deeper breath. Okay, this is due to thoracic pressure. All right, the elevated respiratory rate with the dyspnea, again, they're going to start losing oxygen essentially, and they're trying to speed up to compensate. All right. By the way, if they go from really fast to really slow, now is the time to bag them because they're about to code on you. Okay, so you really need to engage these patients quickly. They don't wait to go to the truck. We start bagging them there and then. All right. So continually reassess for respiratory rate and pattern. Again, above 20, we kind of go, eh. Again, below 12, we really pay attention. But usually that below 12 usually means like below 8 is usually when they slow down that bad. So if they start slowing down, that is a really bad idea. All right, we're going to stop there, and we're going to go into this next video. So again, a little short one. But again, really important to understand. You got to do a good secondary assessment of these patients and ask these questions. And of course, usually you're limited in time to do it. All right, guys, I'll see you on the next one.